So it gives me great pleasure to introduce our next speaker. As you can see, we've had an amazing lineup of speakers. Dr. Volkan Yumuk is the president of and the founder of the Turkish Obesity Society. He's also currently the president of the European Association for the Study of Obesity. He trained in Ankara and did his medical training in the US. He's a full professor, and we're very honored that he's come to speak to us about an overview of treatment of obesity through guidelines. Thank you very much, Volkan.
Thank you. Thank you very much, Sara, for the kind introduction, and I would like to thank you, Mohammed Al Hadad and Johanna Ralston, for their kind invitation. I will be giving you an overview of the treatment options. I believe you have heard so much yesterday on obesity management and the management medications. Mine would be just a brief overview based on guidelines, based on evidence. In the beginning of my talk, I will start with this slide, which I think is very important, and I would say it is important how we speak about and show obesity. That is, I will be using all throughout my presentation the people first language that applies to obesity, and also positive imagery for obesity for the sake of respect and non-stigmatization. The current narrative of obesity is that obesity is a multifactorial disease, chronic disease, that is a gateway to other diseases. It is driven by environmental, genetic, and biological interactions, and not simply a moral issue or a failed willpower. It better be recognized as a non-communicable disease and be prevented and treated as such. As for the physiopathology, as you all know, satiety factors interact with multiple central nervous system centers. The hypothalamus being the major area where you have the appetite and satiety centers positioned in the relevant nuclei, and which are responding to the orexigenic and anorexigenic signals coming from the periphery. The other side of the medallion is that the complications of the disease are based on adiposity. So we should be talking about the amount, distribution, and the function of adiposity. In this case, we have two entities. That is the fat mass disease and the sick fat disease. And as you can see on the left, this is the adiposity-based chronic disease concept. So the fat mass disease leads to pathological mechanical forces, and an example is osteoarthritis. The sick fat disease is related with deranged endocrine and immune responses, which here we have a low-grade chronic inflammation that is related with the, let's say, cardiometabolic complications of obesity. You all well know about the complications of obesity. There's a whole list, and now we're talking about more than 200 complications. Cardiovascular and respiratory complications. And even for respiratory, there is a new concept which is fatty lung, like fatty liver and fatty kidney. Neurological and psychological complications, psychosocial complications, immunology. You all have witnessed the susceptibility to infection and worse infection outcomes during the COVID times. We have endocrine, gastrointestinal, musculoskeletal, genitourinary, and complications and cancers, especially in postmenopausal women. The rates of breast cancer and endometrium cancer are increasing. My last slide related with physiopathology is the science behind weight regain. So the weight regain is not the patient's fault, and it's not the result of a failure of willpower. It is biology. So as you can see here, when we have decreased fat cell mass after weight loss, all the orexigenic and anorexigenic hormones and other factors, among these ghrelin goes up, insulin goes down, leptin goes down, and as a result, with their influence on these specific centers in the hypothalamus, they lead to increased food intake and decreased energy expenditure in order to restore the fat mass that was lost. Now coming to management of obesity, well, this is a comprehensive obesity management center, which is what we call the collaborating centers for obesity management. And it's a very, let's say, dearest initiative, very significant initiative of the European Association for the Study of Obesity. That is a comprehensive center with a multidisciplinary team. And here I'm giving an example, which is my center at Istanbul University. And here we have the core team, which is formed of a clinical psychologist, a bariatric surgeon, an endocrinologist, an exercise specialist, and a dietitian, and also from people from other disciplines whom we refer our patients to. And I believe there are several of these centers here. One I know in Dubai, and we call these centers affiliate centers. And many people came for the exchange program of the COMS to Istanbul, to my unit, from Dubai. This must be an old slide that you have seen many, many times, but this beautifully gives us the current information in regards to the goals and benefits of effective obesity management. Well, our first goal is to achieve weight loss, but that's not the only goal. Our second goal is to maintain the lost weight. But above all, the most important one is to achieve clinically meaningful benefits. That is, reduction in diabetes risk, improvement of the markers of cardiovascular risk, reduction in functional impairment, improvement of quality of life, remission of complications of obesity, and de-escalation of therapy for these complications. I'm also going to cite the five-step approach to obesity management from the guidelines by Obesity Canada. The 5 A's, well, when you're seeing the patient, you ask for permission to offer advice and help treat the disease in an unbiased manner. And then you assess the patient using appropriate measurements to identify the root causes, the complications, and barriers to obesity treatment. Then you discuss the treatment options with your patient. You agree on goals of therapy, and then you engage in continued follow-up and reassessment and encouragement of advocacy to improve care. So the step 5 reminds us that obesity care is lifelong. just to give you the management, the 6 pillars of management from the EASO guidelines that were published in 2015. As you well know, that nutrition, physical activity, cognitive behavior therapy, pharmacotherapy, bariatric metabolic surgery, prevention and treatment of comorbidities form the 6 pillars of obesity treatment. How do we develop strategies? Well, here, of course, we're still using BMI, but not only BMI. We are using waist circumference and the presence of complications. So according to these 3 criteria, we devise a strategy. And then after the diagnosis, we stage the disease, assessing the disease severity. And this is the Edmonton Obesity Staging System that is frequently used. There are other staging systems that you can use. And what it does is it stages the disease according to medical, cognitive, and functional impairments, starting from stage 0, where all of these are absent, to stage 4, where you have end-stage disease. And then this is an algorithm that was generated by our Italian colleagues using the stage, BMI, and age. And according to these 3 criteria, they will develop the best treatment plan for the individual. You see the age cutoff. Well, this was a 2016 paper, so today we don't use these age cutoffs anymore in such algorithms. I'm also happy to talk to you about a new framework for the diagnosis of obesity, diagnosis, staging, and management of obesity in adults. This was, again, prepared by EASO faculty. And here we need to have the anthropometric component and the clinical component for diagnosing obesity. And the conclusion is that for diagnosis, we need to have a BMI greater than or equal to 30, or we have a BMI greater than or equal to 25, and a waist to hip ratio which is greater than or equal to 0.5, plus medical, functional, or psychological impairments or complications. Just citing some valuable information from the other guidelines that EASO has generated. This is a EASO FAD, European Federation for Dietitians, medical nutrition therapy guidance. Well, the first item would be adults living with obesity should receive individualized medical nutrition therapy provided by a registered dietitian. And the second would be calorie-restricted dietary patterns emphasizing variable macronutrient distribution ranges to achieve similar body weight reduction over time. What this means is that reduced calorie diets result in clinically meaningful weight loss regardless of which macronutrients they emphasize. And also in this guideline, the benefits of Mediterranean diet has been mentioned. Coming to physical activity, well, this is an exercise guidance developed by the Physical Activity Working Group of EASO. And here you can see that for weight loss, an exercise training program based on 150 to 200 minutes of aerobic exercise, at least at moderate intensity, has been advised. And for weight maintenance after weight loss, 200 to 300 minutes per week of moderate intensity exercise has been advised. For preservation of muscle performance, then the training program would be based on resistance training at moderate to high intensity. Coming to bariatric surgery, again, we need more data for this, but with the data we have, the conclusion is for all additional weight loss, physical fitness, and muscle performance is that there should be a program based on combination of aerobic and anaerobic, that is resistance training. Behavior therapy. Well, we haven't generated a guidance for that, but depending on the guidelines that have been written so far, you have many approaches, starting from food intake and physical activity diaries, to telemedicine, motivational interviewing, portion control, mindfulness, CBT, and others that could be used according to the capacity of the individual. Coming to pharmacotherapy by obesity phenotype, so phenotyping the obesities, you may select the best medication. For example, for abnormal satiation, you would be using phentermine topiramate extended release formulation. For those who have hedonic eating, bupropion, naltrexone would be the first choice. For abnormal satiety, the GLP-1 receptor agonists would be used, and for those who have a decreased metabolic rate, a low-dose phentermine plus resistance training are advised. Again, staying on obesity management, and especially obesity management medications, again, for stigmatization purposes, we're not using anti-obesity drugs, the term. We prefer either obesity management medications, or you could use obesity medications. And as you see here, the second generation obesity management medications lead to a weight loss that is closer to bariatric surgery. And the new ones coming in on the pipeline will be closer or more to these rates. Coming to the similarities between or among obesity and other chronic diseases in treatment to target is shown here. And if you compare it with type 2 diabetes and hypertension and atherosclerosis, the biomarker target for diabetes is A1C, hypertension, blood pressure, atherosclerosis is LDL cholesterol or non-HDL cholesterol. The reason for target is, of course, preventing complications. And the complications for diabetes, microvascular, macrovascular complications, hypertension, heart failure, stroke, and CKD, and atherosclerosis is myocardial infarction, stroke, and amputation. And for adiposity-based chronic disease, that is obesity, weight loss is the primary target, and then the complications are those complications that I have listed before. So we said treat to target. What is the target? Well, the target is the amount of lost weight and the duration of the maintenance of the lost weight. And it depends on every individual. But what we see here, for the prevention of another chronic disease resulting from obesity, or the remission of a complication of obesity, you need to have a range of weight loss 10 to 15% of the initial weight. And the second generation obesity management medications, semaglutide and tirzepatide, cover that area. And as you see, for cardiovascular risk reduction, the more, the better. We know that when we stop the obesity medication, people regain the weight. And this is an example for semaglutide in the step 1 trial. And for tirzepatide in SURMOUNT-4, again, it's the same story. When you shift to placebo, they gain weight, and when you go on with tirzepatide, they continue losing the weight. Therefore, obesity management is lifelong, and in theory, we need to be using obesity medications lifelong, as we are using medications for other chronic diseases like type 2 diabetes, hypertension, and on. Coming to bariatric surgery, there are indications and contraindications for bariatric surgery, like all treatment modalities. And in our center in Istanbul, we mostly use sleeve gastrectomy and gastric bypass. The mortality is very low. Of course, it depends on the center that it is being done. So that's why we need these comprehensive obesity management centers. And we know that bariatric surgery leads to a greater and sustained weight loss compared to standard care. The SOS study, the Swedish obesity subjects study, the 20-year follow-up, also shows that there is weight regain after bariatric surgery, starting after the first year, and especially significant rise after the second year. And another evidence is that after you use semaglutide or tirzepatide for management of weight regain after bariatric surgery, in this case it is sleeve gastrectomy, the data is from a retrospective cohort study. In 6 months, you lead to a weight loss between 10 to 15% before the surgeons decide to do revisional operation. I think this is a great option. This is also another guideline from EASO telling you about the practical recommendations for the medical management after surgery. And as you can see here, there are several problems arising, and therefore you should be doing, after bariatric surgery, the lifelong follow-up with your team as a comprehensive multidisciplinary center. Nutritional management, micronutrient supplementation when there are deficiencies, management of obesity complications, so you need a physician, internist, endocrinologist, could be a family physician in the team. The chances of pregnancy increases after surgery, so you have to be careful, keen in the follow-up for this. Pharmacotherapy after bariatric surgery for other complications, and also you would be de-escalating the dosage of these medications. Psychological aspects, you should be following these patients for that. And weight regain management is of course very crucial after bariatric surgery. So I'm going to be ending my talk with a paradigm shift in obesity management. Some of our colleagues say that since we have these obesity management medications with very high efficacy as close to bariatric surgery, there won't be a need for other disciplines. That's wrong. We still are going to be working as a multidisciplinary team. So the physician is there for evaluation, prescribing the medication and the medications for obesity and complications. The dietitian is there, not for a hypocaloric diet, but nutrition for healthy eating, nutrition for preserving muscle performance, and medical nutrition therapy for the complications of obesity. We need an exercise specialist for cardiovascular conditioning and preserving muscle performance. We need a psychologist. And we need a bariatric metabolic surgeon to treat severe obesity to target. So thank you very much.
Thank you very much, Professor Volkan. We've probably got time for one question. Oh, Carl's there already. Good morning.
I really enjoyed that talk. Thank you so much. I just wanted to ask you about the treatment to target idea. Because now, obesity is one of the only chronic diseases where we don't have an absolute target. We have an absolute target for blood pressure, we have an absolute target for diabetes, for dyslipidemia, etc. So do you think we will be able, if we do have the science to say that there is a target, will that change how we approach obesity? Will it make obesity more similar to all other chronic diseases that we are treating? And let me say that absolute target doesn't have to do anything with adiposity, right? It could be any target, but would it help us?
Well, as I said, it should be taken as other chronic diseases.
Right.
That's number one issue. The second one is the target may change on individual basis. And the third, it's not only the BMI or other measurements, but I think the parameters in regards to the complications of obesity will be the first target that we should be targeting for diabetes, A1C complications, for hypertension, the targets they have. So I think today that is the best solution that we are following. So if there is a target like hypertension or diabetes, I don't think it would be fitting all, let's say, but I think this is the best conclusion right now that I can make.
Thank you.
Thank you very much for an excellent talk. And this is a small appreciation from us.
I was expecting this.